Hi guys,
Hi.
thank you for joining us. So you're gonna see on the control panel, you can add all your questions that you want to ask, and then also if you want to go live by asking your questions, just go ahead and write live followed by your name and your question, and then you will see a PDF file under the handout tab, and please just don't share that with anyone and enjoy our presentation.
Hi, guys. Good evening. Good seeing everybody today. I am so very glad that a bunch of you are joining us. More than 300 of you are joining us right now for our second pilot episode for VCOP. I am remarkably pleased to be here tonight, and I'd like to start off with just a little bit of some commentary. I was talking to my team last night during the rehearsal for this program that yesterday was a really hard day for all of us. It was definitely for me. I imagine for many of you it was. And so the only thing I wanted to tell you is, number one, I'm really proud of each and every one of you. You have been remarkably resilient as students, as citizens, and we recognize how difficult these times have been for you. And so I just want you to know how hard we are working for you, how much we enjoy the mentorship we provide you. And for the lesson tonight, I wanted to kind of emphasize, we're going to learn some clinical stuff today, medical stuff, diagnosis. That's phenomenal. But if you're going to learn one thing from me, is that it's not just about being good about diagnostics and therapeutics. To be a really good clinician, you have to be a good human overall. So use your place in society as a clinician, as a citizen in healthcare to promote equality, tolerance, love for one another. That's the only way our society is going to move forward. So I urge you to reflect on the events from yesterday and take it as an opportunity to grow from it and make me proud, because when my generation goes, guys, it's up to you. And I want my daughter to be in really good hands. So that being said, I thank you for indulging me for that quick minute or two. Let's get rocking and rolling with pilot episode number 2. I'd like to introduce you to the team. Next slide, please. Dr. Mark Rendon, you're going to be seeing him tonight. He is actually working clinically, but he went ahead and recorded the episode from us this past Saturday. He's a phenomenal clinician. We got Dr. Jessica Hernandez, a dear friend, who is a phenomenal educator, a phenomenal physician as well. You got me. I'm the least intelligent of the group, but I try. We got Dr. Sigrid Nasser. She is also working clinically tonight in the front lines. And so I will be handling the Q&A for you. And last but not least, Dr. Malhi, who is an amazing human being, a remarkable physician, and a great colleague to have.
All right, guys, so today we're going to kind of start with a little bit of conversation on how we can potentially build empathy with patients, specifically around the difficult task of delivering bad news. So the encounter that you're going to see recorded with Dr. Rendon will really hone in on some of the skills required for this really difficult interaction with our patients. But we want to know that, this is something that's very important in medical training. There's certainly time and place for the technical knowledge, for the anatomy, the pathophysiology, but none of that holds a lot of value if you're not able to convey that to your patients or to pass along some sense of reassurance, compassion to your patients. So the American Association of Medical Colleges has a list of core competencies that we have always promised you that we want to be able to focus on during these sessions, so that you feel like we are addressing the things that are important for pre-med students and medical students to be skilled at as they go forward in their medical training. And so today we're going to be focusing a lot on those interpersonal competencies. While we'll chat about cases and chat about the interesting medical histories, etc., we want you to keep in mind, in the back of your mind, kind of what social skills are required here. And all of this is done with an eye towards a service orientation, which means that we're recognizing that in our role as physicians, we really do have a lot of responsibilities to our patients and to the society in which we are serving. Remembering that these social skills include the ways that we interact and behave with our patients and how we can appropriately adjust our behaviors based on the cues that we're getting back from our patients, from their family members, and how we're able to respond to those. Making sure that in all that we're doing, we're treating others with respect. And that includes not only our colleagues in medicine and our healthcare team, but also our patients and their family members. And again, of course, having a real focus on the oral communication that comes with these difficult, sticky situations somehow, how the words that we use matter, how the language that we use matters, and how the body language that we portray really has an impact on the way that a patient is able to understand their own medical care, but also how they come to trust the relationship that they have with not only us as their physician, but with medicine overall. And now this is all under the context of, like I said, breaking bad news, which is, of course, a very difficult duty, but an important one for a physician. You don't get a lot of preparation for this sometimes in your medical training. And even though we often focus on technical proficiency, we really do need to have some sort of a focus on communication skills, which thankfully, I can certainly speak to medical schools as my own experience, but so many other healthcare areas are starting to realize that this needs to be incorporated into the training that we receive. We can go ahead and go to the next slide.
We're going to go ahead and deploy the poll, Rachel. So I'd like our students to reflect for just 1 second. You know, the competencies we're presenting tonight, in addition to the clinical ones, are super duper high yield. But I want to learn a little bit about you, kind of what you know. So which skill do you think a good clinician with good bedside manner must possess? And there's no wrong answer, no right answer either. I want to see what you guys think. Is it the medical knowledge, kind of the book learning? Is it active listening? At our last session, we discussed what active listening is all about. It's not just an open ear, it's an interaction. What about empathy? That is much different than sympathy, okay? And or is it really good posture and eye contact? All of these are really good skills. I just want to see what which of these you value in a clinician with good bedside manner. Once again, I remind you, there is no right answer, no wrong answer.
Right, I'm going to close it. There's about 90 of them that responded.
All right. Let's take a look at what you guys have for us tonight. We got a good chunk for active listening. Empathy is a big one, good posture and eye contact. So tonight we're going to be discussing a little bit on some of these. And remember that it is not just about the medical knowledge part, it's about the other skills. Dr. Molly.
All right, perfect. Let's go to the next slide. Are you all able to see the next slide?
I still see the quick poll. Maybe Steph can stop sharing and resharing.
Yeah, I'm not seeing where you close the poll, but I'll just reshare my screen.
While we're working on that, just a little bit of background again. Just remember that bad news really is defined as anything that is going to potentially dramatically or negatively impact a patient's view of their future. Now, sometimes that's not necessarily things that we as physicians think is bad news, but really anything that changes the way that a patient feels that their life is going to play out over the upcoming days, weeks, months, or years can be considered something that is a difficult or bad news situation. And when we're talking about the background when it comes to medical training in this, you know, back in the mid 1800s, the AMA had their first code of medical ethics for physicians. And interestingly enough, at that point, they were talking about the sacred duty of physicians being to conceal any sort of information that may discourage a patient or depress the patient's spirits, which is of course very interesting because in the past several decades, we've kind of given way from those traditional paternalistic models of patient care towards a model more focused on patient autonomy, which really requires a patient to be able to be empowered with all the information that they're able to have available to them about their own medical care. So keep in mind while we're talking about all of this that not all of it is difficult just from the patient's end in receiving the bad news, but it's also tough as a physician to be able to deliver that bad news to our patients, right? It's an unpleasant task to begin with. You don't like taking away hope. You don't like being the bearer of bad news, as we say. And so, especially in the hectic pace of what can be your clinical practice, whether you're working in an outpatient clinic or you're working in the emergency department or in the inpatient setting, it can really take time out of your clinical day, and it is difficult to do because it can be similarly heavy for the person delivering that news. Go ahead and advance. So there's a mnemonic that I want to talk about. It's the ABCDEs of delivering bad news. And this is something that's been put forward by the American Association of Family Physicians, which has so many wonderful resources for you to look into online about how you go about this difficult task of delivering bad news. So to start with, A is about advanced preparation. So part of that is making sure that you're familiar with the patient's clinical information. And so that really does take into account the need to have that medical knowledge base so that when you're passing information along, you understand what the repercussions of that information are, and you're able to relay it in a way that's understandable to the patient. At the same time, you have to be able to the best of your capabilities, given your clinical practice situation, come up with a way that you can deliver this news in potentially a comfortable, quiet, private location. When you go in, make sure you've mentally kind of rehearsed some of the information that you want to relay and the big talking points that you want to be able to discuss with your patients. This will get better with time the more you do this, unfortunately, but it is important to know that you should have for yourself some objectives of the important information that needs to be relayed to the patient. And of course, if you've not done this before, part of the advanced preparation here is watching a colleague or someone more senior to you go through this process. As uncomfortable as it may be to witness someone receiving bad news, it's an important part of your own training and how you get better. Next is B, which stands for building a therapeutic relationship and environment with your patient. So part of this is, easier done in a clinic setting where maybe you have a longer term relationship with a patient, but understanding what a patient's preferences are for how much they want to know, and knowing family members that are available for support, knowing who the patient would like present with them when this information is relayed. And then also making sure in your open and honest communication that you are able to foreshadow the bad news. Build a context by which the patient isn't taken off guard. And sometimes that can be something just as simple as saying, I'm so sorry, but I have some bad news to share with you. You want to be direct, and you want to, through that honesty, be able to develop a relationship where the patient trusts you, as difficult as it may be. And now, of course, depending again on your relationship with that patient and depending on the social cues that you're receiving, which really varies patient to patient and encounter to encounter, you can use touch where appropriate. If that means resting your hand on the patient's hand or putting your hand on the patient's shoulder or providing that sort of physical comfort, if you feel that that is appropriate in the setting, please do that, because that really, again, helps you connect with the patient and can provide some consolation. Next with C is communicating well. And so part of that, again, is, what I think is one of the biggest skills that I've picked up, and I think what has made it so much easier for me as a physician, is before I start talking, let the patient talk. So part of that means when I start my encounter, asking them, you've had a lot going on recently. Tell me what you understand about what's been happening, what we've talked about, and what you expect as we've found out some more information about your medical health. And that allows you to be on the same page as the patient, to understand whether the delivery of the bad news is going to completely catch the patient off guard, or whether that's something maybe they've been expecting, and you can then tailor your conversation to that. That also means allowing space for some silence, allowing space for the patient to process this information, and potentially even allowing space for the patient to cry, express their emotions, and to have tears. It's uncomfortable initially, but this is where you are going to stand out as a skilled clinician and a skilled provider in these difficult settings. And again, remember that a lot of what you say, the patient may not remember afterwards. Write things down for them, use diagrams, give them information, give them opportunities to continue to ask questions. D is really, again, dealing with the patient's emotions and with the family's reactions as well. Be cognizant of how the patient is responding. Continue to be empathetic, and that's saying, I'm sorry. And if they're asking questions that you don't have answers with, be comfortable with saying, I don't know, but we can get you to people who will be able to give you better answers, clearer answers about the next steps moving forward. And again, if you are feeling emotional, you can express that to the patient. And I don't think that's a bad thing. And I think it, again, allows this human component to come into medicine. We as physicians are not robots. We have feelings, we have reactions, we have emotional responses to the situations that we are dealing with. And I think that you should give yourself the room and the space to, along with your patient when it's appropriate, be able to share in that experience. And again, E at the very end is another reiteration of the same thing. Encourage those emotions, validate those emotions, offer hope when it's appropriate, but be realistic. Even if it's not something that can be cured or can be entirely fixed, be encouraging about what options are available, or if there are options available. Discuss what you know as the potential prognosis and explore what all of this is really meaning to the patient. And again, at the end of the day, you also need to be attentive to your own needs. As the physician, when you're carrying around the burden of so much potential discouraging or bad news to your patients, you have to understand that there could potentially be countertransference, which is a concept that we talk about a lot in psychology and psychiatry, but it can trigger your own sorts of responses emotionally to these situations. Make sure that you have a support system set up for yourself as well, whether that means formal counseling or therapy, or just the support of your friends or family. Because unless you are able to take care of your mental health in these situations, you're not going to be a great physician or a great provider to your patients. So,
Dr. Malhi, that's a phenomenal overview. I do want to share with the group that this is not something natural to us. Delivering bad news is not something natural, and it is really a physician's job to do so. It is a nurse's job to do so, a PA's job to do so, a paramedic's job to do so. And I've actually seen this botched on many, many occasions when people are having the worst days of their lives. So I'm going to encourage each and every one of our pre-healths to take a good lesson from what you're learning today and build from it. We do have a question. How would you be able to know how much a patient would want to know? In theory, wouldn't a patient not want to know terrible news? And Dr. Malhi, what do you think about that?
yeah, that's a great question. I think part of our perception of what a patient wants to know depends a lot on the interactions you've had up until that point. Again, if you are their primary care provider or you are a specialist provider who has built a relationship with a patient, you can pick up a lot of cues from there. Now, in a more limited setting, especially in the emergency department, which is where all of us are practicing, it can be hard to pick up those cues in a very short time period. But I think I have started to, number one, really give credit to patients in that as much as we anticipate that patients don't want to know difficult news or discouraging news, in providing an empowerment for patients, I think I've learned that patients are actually better equipped to handle a lot of this than we often think that they are. And so I might say in an encounter, you know, I have some bad news. I'd like to share with you what I think is going on. Are you comfortable with me passing along this information to you? Or is there someone else, whether a family or a friend, that you would like me to share this information with? And then they can potentially pass that information along to you. So be open about it. You don't have to hide that you don't know exactly how to go about this. Everyone understands it can be a tricky situation. Just ask the patient. Let them know that it's not great news potentially, and just let them know that you have the option of talking to someone else, but you're more than happy to share everything you know with the patient as well, and kind of let them take ownership of their care.
Thank you so much. We're going to take one live question before we go to the next portion of the presentation. And
Sure.
so Cheyenne, I'm going to call on Skylar P. If we can unmute Skylar P. And Skylar, go ahead and ask your question. Keep it pretty brief. And I'll go ahead and take that question.
Sure, let me go ahead and find them here. Skylar Price, okay. Unmute. There we go.
Hear me?
I hear
We
you.
can hear you, Skylar. Welcome.
My question was for if a patient didn't have a support system present or available, how do you kind of go about that? And then talking about physical contact specifically with COVID-19 restraints that we have now, how has that changed for physicians?
Thank you, Skylar, for your question. That is an outstanding question. Part of Part A in Dr. Malhi's presentation here, advanced preparation, one of the skills that you have to have is making sure that you have the right people in the room. Rarely do I do a notification, especially of death, with only one person in there, unless there is absolutely no one else. But I will always have a chaplain with me. I will usually have one of our treating nurses with us so that there's more than 2 people in the room. And at the very least, the patient has somebody when I need to step out and go take care of the patient. A chaplain can stay with them and nurture them a little bit. In terms of COVID-19, that really placed a great strain on that relationship, but we have made exceptions, especially in really tough situations, because notifying somebody of a really bad outcome is not to be taken lightly. So we take every precaution, invite a limited number of very close next to kin into the room so that the notification can be done in a humane and positive fashion. Thank you, Skylar, for your question.
Thanks.
Thanks everyone for your great questions. All right, let's go ahead and move on to Dr. Rendon's patient encounter and watch this video. Keep in mind what we chatted about and see how Dr. Rendon puts that into practice in this.
Ms. Patel, thank you for sharing that information with you. I'm sorry that you're so uncomfortable. I just kind of want to summarize everything, make sure that I have the story straight. Okay, so for the past week, you've been having headaches that you've never had before. You're noticing that they're primarily in the morning, and a couple of times they've woken you up for your sleep. You describe them kind of as a throbbing and kind of just generalized headache, not really in one spot of your head. Mm-hmm. You've also noticed that you've had some nausea and vomiting throughout the past week. Is that right? You mentioned you threw up a few times. Yeah. There's no blood in your vomit. And you also mentioned kind of oddly that you've been noticing you've been forgetting a few things and you feel a little bit confused at times. Is that right?
Yeah, that's right.
Okay. But you haven't had any fevers or chills. Have you had any other symptoms at all along with this?
No, I just, I work as a school teacher, and sometimes when I'm trying to come up with my lesson plan, I feel like I can't really concentrate sometimes, and it's just really affecting the way that I do my work.
Yeah, that must be very distressing. I'm sorry to hear that. But you're a school teacher. What grade do you teach?
I teach 2nd grade.
Oh, yeah. How is that? Sounds like it's very rewarding.
Yeah, it's a lot of fun. I really enjoy it.
Awesome.
Yeah, I just want to make sure that this headache isn't something really serious.
Yeah, absolutely. And I'm with you. The history concerns me a little bit. The fact that you've never had these headaches before, and the fact that they're worse in the morning. The majority of headaches are benign, but I do want to ask you a few more questions, and then we'll move on to the neurological exam.
Okay.
So I'm going to ask you about your past history, so I'm going to switch gears a little bit. What medical problems have you had in the past?
I haven't had any medical problems.
Okay. Have you had any surgeries in the past?
I just had my appendix taken out when I was 12, but that's about it.
Okay. And do any medical problems run in your family?
Not that I can think of.
Okay. Any family history of like migraines or aneurysms, brain aneurysms, anything like that?
No.
Okay. I'm going to ask you a few questions about your personal life because this can have an impact on your care. So I already know what you do for a living. You mentioned that you're a school teacher. Mm-hmm. How long have you been teaching?
This is my 3rd year now.
Okay, awesome. Very good. I'm happy to hear that. And who all lives at home with you?
Just my husband and my dogs.
I have to ask you a few other personal questions. Do you use any drugs or do you smoke?
No.
Okay. Any alcohol use at all?
No.
Okay. And do you have any other concerns? I know you had mentioned that it's affecting your ability to teach, and I'm sorry to hear that. I hope we can get to the bottom of this. Do you have any other concerns?
No, I just want to know what's causing my pain.
Yeah, and I'm with you. We want to move forward with the evaluation. The next step would be moving on to the neurologic exam. Are you comfortable with that?
Sure.
Okay, great. All right, we're going to move on to the neurologic exam, Ms. Patel.
Okay.
So first, I'm going to shine a light at your eye, okay? Look right at me. Very good. Very good. Great. Okay. Next, can you follow my finger just with your eyes, okay? This is part of your cranial nerve exam. Excellent. Great. Good. Very good. Okay, now I'm going to examine your 5th cranial nerve here. So can you feel my fingers on both sides of your face there?
Yes.
Does that feel the same there?
Mm-hmm.
Okay, very good. Now, can you stick out your tongue, move it side to side? Very good. Say ah for me. Just want to see your palate rise. Very good. Now, can you lift up, raise your eyebrows? Very good. Then can you smile for me really, really big? Very nice smile, nice and symmetric. Good. Okay, now, can you close your eyes for me? Okay, can you hear my fingers rubbing?
Yes.
Okay, which side do you hear that on?
The left.
Okay, what about here?
The right.
Okay, very good. You can open your eyes. Good. Can you shrug your shoulders for me? Very good. And then can you turn your head towards my hand? Turn your head towards my hand. Okay, very good. Looks great. Now I'm going to move on to the motor exam. Can you put your arms out like this and keep them nice and strong, nice and strong? Very good. Excellent. Now push out against me like you're extending your triceps. Good. Pull me in like you're working out. Oh goodness, nice and strong. Now cock your wrist up like that. Don't let me move them down. Excellent. Good strength. Can you push your, lift your leg up against my hand? Lift up your leg. Very good. Here as well. Very good. Kick out against me. Pull me back in. Good. Kick out against me. Pull me back in. Good. Now I'm going to check your sensory function. Can you feel that on both sides?
Yep.
Does that feel the same on both sides?
Yes.
Okay. Can you feel that on both sides?
Yes.
Does that feel the same on both sides? Okay, very good. Now, can you take your finger and touch your nose? And touch my finger with that same finger. Good. One more time. Very good. Can you do that with your left hand? Okay, touch my finger, touch your nose. Very good. Now, this is also part of your cerebellar exam. Can you take your right heel and run it in a straight line up and down your left shin?
Like that?
Very good. Like right along the front of your shin. Okay, very good. Can you do that on the left? Okay, right along the front, right there. Good, very good. Excellent. Good. Okay, now I'm going to have you stand up. It's called a Romberg exam. Can you put your hands out in front of you, arms out in front of you? This, and then close your eyes. Let me know if you feel like you're going to fall. Okay. Very good. You can have a seat.
Okay.
Well, overall, your exam looks pretty good. But again, like what you were mentioning with the history, with some of those components of the history, the fact that you've never had this headache before, the fact that it was worse in the mornings, I still do want to proceed and get some imaging of your brain. Okay. Let's start with the CT scan, but if the CT scan looks okay, I actually want to get an MRI as part of our evaluation today. Are you okay with that?
I'm okay with that.
Great. Hey, Ms. Patel.
Hey,
How are you holding up?
doing pretty good.
Thank you for your patience. I know it can be stressful waiting for results. I have had a chance to look through the results of the workup that we've done so far today. The blood work all looks good. I didn't see anything remarkable with your blood work.
Okay.
But I am a little bit concerned about the imaging that we received. I looked at the MRI myself, and the radiologist read it, and unfortunately, we do see a mass in your brain.
Oh no.
Yeah, it's pretty concerning. So we see a mass on the right side of your brain, and to be honest with you, it is concerning for a cancer. And the way that the radiologist read the MRI, he read it that it's likely what's called, and this is a fancy word, a glioblastoma, which, to be honest with you, it's the worst kind of brain cancer that you can have.
Oh my God.
I'm really sorry.
What does that mean?
Well, so the next steps would be to involve several folks. I want to talk to my neurosurgeon right away. Sometimes these can need surgery. I want to talk to the oncologist. We'll probably have to get them involved after we talk to our neurosurgeons. What other questions do you have? I want to show you the imaging, but I want to see if you have any other questions first.
I mean, does this mean I'm gonna die?
If it is in fact that type of brain tumor, if it is that type of cancer, the likelihood of survival is very low, and the prognosis long term is generally quite grim. Now, I don't want to jump to that right now. I do want to certainly get my colleagues involved, get the neurosurgeons involved. But if it is what we're thinking, it's unfortunately the worst kind of brain cancer that you can get. Here, let me show you. So what we're seeing here, we're identifying a mass there on the right side of your brain, and it does look like it's causing a little bit of swelling, a little bit of what we call edema, and I think that's probably what's been causing your headaches and your nausea and vomiting. And some of it even extends into the frontal lobe there, and I think that's honestly what's been causing your confusion and kind of those memory lapses you've been having over the past week. Okay. This is a lot to take in.
Yeah.
What questions do you have right now?
I don't know. I don't know what's going to happen next.
Yeah. So the next step is to talk to the neurosurgeon. I'm going to give him a call, let him review the images, and then I'll keep you updated on to the next steps. Is there any chance that we could have your husband come in so I could discuss this with him as well?
Yeah, I can call him.
Yeah, please do. I want to have him here so we can discuss this, and now I'm going to go page my neurosurgeon.
Okay.
Okay, and then I'll keep you updated after any other discussions.
Thank you.
All right, thank you.
That deserves a big round of applause, a virtual applause for Dr. Rendon. It's no surprise he's so revered in our residency program as an emergency doc. Let's go ahead and deploy poll number 2. Rachel, if you don't mind, and remember there's no wrong answer, but I want to pick your brain a little bit about what you thought Dr. Rendon demonstrated best, given what you know now, what skills he utilized. He used active listening very well. It's not just opening your ears or being quiet, it's active listening. So he elicited the patient's concerns and stated that very specifically. He also took interest in the patient as a whole. He was taking a social history as well. Part of being a really good doc is understanding the patient's social situation, their support structure, etc. Shares thought process with the patient. As he is thinking clinically, he is also sharing these with the patient. So that is shared decision making. That is empowering the patient in their clinical care. And then I'm always so jealous of Mark Rendon and his tone of voice. That man could make me feel better about just about anything with his tone of voice. So soft-spoken yet firm and intelligent and knowledgeable at the same time. So I want to hear what you all have to say about Dr. Rendon's physical exam and his interview skills and his delivering of bad news.
All right, about 80 already voted, so I'm just going to close it and I'm going to share.
Looks like, yeah, kind of relatively, pretty even for B and C, it looks like. Most of you thought that taking interest in the patient as a whole was one of his best skills. Share thought process with the patient, absolutely. And so remember, there's no wrong answer. So thank you so much. It looks like you guys were paying attention. Let's move on to the next portion.
Yeah, once again, Dr. Rendon did a really excellent job of describing and showing in practice so many of the things that we briefly chatted about. You know, at the beginning, he took a moment to summarize what the patient had told him so he could make sure that everyone was on the same page. And like Dr. Salazar mentioned, he really took an interest in the patient, found out she was a teacher, asked a little bit about teaching. All of that stuff helps build your relationship, especially when you have a limited period of time. He was very honest about what he was thinking. He said, you know, these things that you're telling me really do concern me, so I want to look into this a little bit more. Asked her what her concerns were, which is so important to elicit, what are you worried about? And that's a question that I use a lot in the emergency department, and especially when patients are coming in with vague symptoms or I'm not entirely sure what their concern is. I'll ask, what are you worried about? What really concerned you today? What would you like to know that would make you feel better about what's going on, so that you know how to connect with the patient? And then he was very reassuring and encouraging throughout the exam. It's hard to know when you're being examined, especially a neurological exam or a cardiopulmonary exam, whether the findings are good or bad. And so he told her, you know, great strength, or you're doing well, or that's excellent. And that really helps give the patient an opportunity to be a part of the examination. He was honest with all the information he had afterwards and took time to elicit questions from her and give her next steps, as well as offer her the opportunity to have her family member, have her support system be involved in all of this information that was being revealed. So if we go to the next slide, very quickly, I'm not going to spend too much time on this. There we go. We're going to chat a little bit about the diagnosis that Dr. Rendon provided, which is glioblastoma multiforme. He was not wrong in saying it is one of the worst types of brain cancer that you can have. And I'll just take that moment to say, using words like cancer and death is so important when you're delivering bad news. As much as you may have a tendency or an inclination to use euphemisms to kind of blunt how difficult this conversation may be, that leaves the patient often feeling more confused. So instead of saying, if you're passing along that someone has died, don't say the patient has passed away, or we did everything we could for the patient, but we weren't able to save them. At some point, be able to say, your family member or your friend has died, so that they know directly what is going on. And don't just say this is a mass or a tumor or concerning for a malignancy. Avoid medical jargon. Try to use words that lay people will understand, and use words like cancer if those are important and pertinent, because that again helps clarify for the patient what's going on. So glioblastoma is one of the most primarily original brain tumors or brain cancers, as opposed to a metastatic cancer that occurs from another primary source. It is the most common malignant primary brain tumor in adults, and it has a median age of onset around 55 to 60, can certainly happen younger or older. A lot of patients here, even with maximal therapy, have a high rate of recurrence. And so patients present with a lot of the things that our patient was mentioning. So some big headaches, can have seizures depending on where the tumor is in the brain, and then can have some focal neurologic deficits, some weakness in an extremity, changes in sensation, difficulty speaking, or differences in their speech from their baseline speech, trouble with visual or spatial functioning, and also cognitive dysfunction, like our patient mentioned, in terms of being a little bit confused or foggy or not being able to concentrate. The diagnosis often is based on imaging and then requires a biopsy. So the image that you're able to see on the screen, on the left side of that image, which is the right side of the patient's body, you see the bright white spot, and around it is a little bit of a gray area. So the bright white is the bulk of the tumor. There's some variation in the shades there, and that's because there's often some necrosis or dying of tissue in the middle of this brain mass. And then around it is a lot of the edema or swelling that occurs as an inflammatory response to the actual mass being in the brain. And now the treatment really differs based on if you're seeing the patient in the emergency department, where you need to start thinking about getting your neurosurgeons on board for potentially excising this mass or removing the mass from the brain, biopsying the mass, and also starting patients on steroids to help decrease swelling, and potentially even seizure medication to prevent potential seizures as a result. And again, like we had mentioned and Dr. Rendon mentions, there is a very poor prognosis, unfortunately, for glioblastoma. Like I said, a high rate of recurrence and poor overall survival, really only ranging from 1 to 2 years in most of our patients after the time of diagnosis. So I'm going to pass along now to Dr. Hernandez, who's going to go through a lot of our case vignettes so that you guys get some clinical case experience as well.
Before we have Dr. Hernandez, I want to address the 1 or 2 questions, Dr. Malhi. I'm going to try to lump 2 of these. One of them, are using phrases like grim outlook and worst kind of brain tumor too honest? It seemed almost harsh and pessimistic. I understand being honest, but it seemed like very strong wording. Is that typical? And I'm going to lump that in with, in some cultures, it's not appropriate to disclose a diagnosis to terminally ill patients. How should one approach that situation?
Yeah, those questions are great. And so much of this is going to kind of formulate as you take back cues from the patient themselves and from their family members around them. If you feel like you have enough information to be able to definitively say that there is a poor or grim prognosis, you should certainly be honest again with your patient. Every provider, every physician is going to have a different take on the nuances of how to pass along this information, especially in the emergency department. And again, that's where my experience stems from. A lot of times I think being direct is the best approach. Now, when it comes to, again, our clinical setting, most of the time we don't have all the answers. We will have a CAT scan that shows something that might be concerning for malignancy, in which case I would say things like, this is very worrisome for a cancer, but we won't know until you get a biopsy or we get further information. If it is cancer, it can have potentially a poor prognosis, which means that there's a lot of worrisome potential for side effects and for your long-term survival. Those sorts of things, depending on your type of patient, is fair game to be able to say. But again, take the social cues from the patients. And of course, like I had said briefly a bit earlier, talk to the patient and talk to the family members beforehand. When you go in and say, potentially I have some bad news, ask the patient, are you comfortable receiving that information? Would you like me to give you all the information I have, or would you like to defer to a family member?
Gauging the patient's level of education, seeing their emotion is going to be part of your initial assessment. And in my opinion, empowering patients in their clinical care involves sometimes delivering really tough news. And I've received many notices over the years and thank you notes for being honest and open about how tough things were and how tough the prognosis was. So, all right, Dr. Hernandez, thank you so much. Let's get to your part.
Okay, please advance the slide. I'm Dr. Hernandez, everyone, and we're going to switch gears and just go into some rapid fire clinical vignettes. So I hope that you enjoy this portion of our presentation. So let's start off with our first patient. So first patient is a 45-year-old female with no significant past medical history, and she comes in complaining of about 8 days of pain to her abdominal area. She said the pain is burning, it's intense. She said that initially she just felt pain, and then after about 5 days, she developed a rash to the area. So I'm going to just pause here for a second, and I want y'all to think and just, what other questions would you want to ask the patient at this time? If you want to just write it in your chat box, think about it. What other information can you get to kind of bring you closer to your diagnosis? And in the meantime, I'm going to ask our panelists. So let's start with Dr. Salazar. So what's one question that you would want to ask the patient at this time?
I usually like to ask if this is our first presentation for it. It gives me a good idea about the kinds of things that could be a first-time presentation, but if they've had it multiple times, that's another different one. And I'll also point out too that we need to expose patients' skin. They can't be in their street clothes, by the way.
That's a good question. So this patient would say that this is her first time having this pain. She's never felt anything like this so intensely. So we're going to move now because you're going to do your focused physical exam. And so let's take a look at what we see. If you can advance, please. So this is what you see when you lift up the gown. And so it was a really good point what that Dr. Salazar made is that you need to expose the skin because you might just think this patient has abdominal pain. It can send you down one line of thinking and you can maybe examine the area over their clothes and completely miss that this rash is there. So Dr. Malhi, can you tell me how you would describe this rash if you were going to document this on your physical exam?
Yeah, so most rashes I start with describing as erythematous lesions, which basically means some sort of red rash. And then I would say that there are some discrete lesions. They are, I would say, where they're located. So I would say on the, looks like left lower abdomen. And I can see from what I can tell that there's some crusting over those lesions as well. So I would include that and say that I don't see any particular drainage or discharge, and then depending on my exam, I would add in whether there's any warmth to the area, whether they're tender when I touch them, etc.
Excellent, excellent. So let's move. So I want so before we move to the next slide, I just want everybody to think, because this is information that you have. So just think about what your diagnosis is. And again, type it in the chat box. We're not grading you, so go for it. All right, let's advance to the next slide. So the diagnosis here is herpes zoster. This is a very classic presentation for this disease. And so herpes zoster is actually caused by the varicella zoster virus. We also refer to it as VZV. This is the virus that causes chickenpox. So this is really interesting because how this works is, people get infected with chickenpox usually as a child, and this virus will live kind of along there in the ganglion of the neurons in kind of your spinal canal for years and just lay dormant, right? And then can be 50 years later, there can be some stressor or maybe some dip in immunity, and all of a sudden a patient can have pain and then break out in this rash. And what happens is that this virus reactivates and inflames the nerves. Now, it's usually rash and pain along a dermatome. So your nerves, when they kind of go through your body, they innervate your organs and they innervate your skin. And so whichever kind of nerve pathways are the ones that are infected usually innervate a certain level or certain area of your body. So when the virus causes inflammation, it usually sticks to kind of along that pathway. So that's how it shows up on your skin. Now, it usually is only along one dermatome, and it usually does not cross the midline, but I have seen cases where that does happen. So the patient may or may not have a rash. So if this patient had presented in the initial stages of her disease, there may not have been a rash at all. And so you have to, kind of just have a high index of suspicion. It's on her abdomen, so it could be possible that somebody will do a whole workup for abdominal pain, looking for kind of intra-organ disease, where they may have not found any. This patient could potentially be discharged and then come back when a rash breaks out, and then that would really explain kind of why she was having this intense pain. So the patient may or may not have fever, malaise, headache, fatigue. They can also have eye involvement or ear involvement. In terms of diagnosing this disease, it's usually a clinical diagnosis, which means it's just seeing this very typical rash. And so again, the rash can look vesicular, so it can look like, it can also sometimes look like pustules. And then the photo that we showed you here, at this point, the lesions have looked like they had already crusted over. So, and it kind of goes along like maybe one line, what we call a dermatome. Treatment is, you can start with just calamine, some lotions or calamine lotions, and that's just for local treatment. And you want to give pain medication because this is quite painful. So analgesics, a lot of times opioid medication. Antivirals are going to kind of be the mainstay of treatment here, and plus or minus steroids, which is a little controversial. Now, some complications for this disease is that they can have persistent pain. So even when the rash resolves, they could have pain for months and maybe even years sometimes, which is really unfortunate. They can have involvement of the CNS. They can also have involvement of their eye, which can maybe lead to blindness. And you always want to think about it too, especially if you see that it may cross more than one dermatome, or if it crosses the midline. You may want to think about if that patient is immunocompromised in some way. So sometimes, you may want to offer a patient an HIV test, if they, don't have any medical problems, or if you take a social history and you think that they may be at risk. Anything like that. So the disposition is usually home, unless they may have some immunocompromised state, or they're presenting where it crosses the midline or it looks more disseminated, then you may have to bring them into the hospital. Okay, we are gonna move on to our second case. So for this case, we have a 36-year-old male with no significant past medical history who's complaining of pain to his right toe. So the pain is 9 out of 10, sharp, and worse with walking, and it's associated with swelling, redness, and discharge. So I'm going to pause here again, and I'm going to have you think about what other information you might want to ask from this patient. Type it in the chat box if you please. And in the meantime, Dr. Malhi, what is one question that you would want to ask at this time?
Yeah, I would probably ask if they recall injuring the toe in any way, whether it's a stub toe or what kinds of shoes they wear, what they do for work, or if they had any sort of trauma to the toe.
Yeah, so that's a great question. So in this case, I mean, the patient says that he did remember maybe stubbing his toe, but it wasn't that bad when it happened. Maybe he had a little bit of pain at the nail, but nothing really significant that he was concerned about. So now you do your focused physical exam and you see this image. Let's advance. Okay, so this is kind of what you see when you do your physical exam. Dr. Salazar, how would you describe this physical exam?
So we have some edema, which is swelling, some erythema or rubor, which is redness, and we got some milky, looks like purulent material, all in the paronychium of the, that's going to be the right great toe. I see some erythema perhaps proximally, which means kind of closer to the patient center of the body. You see it atop the foot right there.
Okay, great. So I want everybody to kind of think about what their differential is and what they think this case is in particular. All right, let's advance to the next slide. So this is a case of a paronychia. And it's difficult to pronounce, but you kind of got to get used to it. Paronychia. And so a paronychia is essentially a localized infection to the nail fold and the periungual tissues. It's usually caused by Staph aureus, but can also be fungal. And it's commonly triggered by nail trimming, nail biting, any nail trauma. And it typically presents with erythema, pain, and fluctuance. Now, when you have that fluctuance there and what kind of looks like that milky yellowish, substance underneath, that's usually indicative that there's an abscess formation. And then that redness that Dr. Salazar commented on kind of below may be signs of what we call cellulitis, which is just infection of the surrounding tissue. So that's kind of important to distinguish as well. So here, this is also a clinical diagnosis, meaning that when you see the physical exam finding, you know what it is. If there is some discharge or purulence, then you can consider sending a wound culture to kind of narrow how you will treat this. So the treatment does involve incision and drainage of any of the purulent fluid, subsequent soaks, and especially if there's a cellulitic component, you do need antibiotics. Oral usually, you can also consider IV. Now, some complications may be that it can become chronic. They may need further treatment as nail removal, or they may need surgery down the line to kind of keep the area open if it continues to get reinfected. The disposition usually, I would say, is home after you perform an incision and drainage. However, there may be sometimes there may be some complicated patient factors, or if the cellulitis is spreading very quickly, that you may want to keep the patient in the hospital with IV antibiotics. Now, I wanted to go back to, so let's advance, because I want to kind of zoom in on this picture, because there's something going on in this photo if you picked up on it. So there is a kind of syringe and a needle going into the patient's foot there, or toe. So Dr. Salazar, do you want to maybe describe kind of what's going on here?
So this picture is showing what a clinician will do when they're trying to anesthetize or numb up the area so we can perform an incision and drainage. So we use what's called a digital block. So right there, the clinician is injecting an anesthetic, usually lidocaine, bupivacaine, for example, into the toe in anatomical fashion, so we can basically anesthetize the area, making the procedure a lot more tolerable for the patient. Otherwise, you can only imagine a clinician taking a little blade to that very sensitive area. That would be remarkably painful. So clinicians, especially those in family medicine, internal medicine, emergency medicine, and surgery, are going to be really good, but I consider emergency medicine the top notch when it comes to digital blocks.
Dr. Hernandez, I don't think we can hear you.
Thank you. Okay, let's move on to our final case now. So here we have a 25-year-old male who also does not have any past medical history, who comes in complaining of 2 days of pain all over his body, especially in his arms and legs. The pain is 7 out of 10. He describes it as achy and worse in his muscles. He denies any fever, cough, cold symptoms, dysuria, which means pain with urination, but he does note that there is some dark urine over the past couple of days. So, Dr. Salazar, what other questions would you want to ask this patient at this time?
With this type of history, given it that it's a young person, probably they don't have significant medical history. So I'm going to think about some unusual causes of discomfort, and I would want to know kind of what is the distribution of the pain in the muscles. Is it more distal, like in the extremities, or more central? The differential diagnosis is quite a bit different.
Yeah. So he feels achy all over, but it definitely is worse kind of out more in the extremities. And so kind of doing a focused physical exam, you don't really find kind of much going on. I mean, maybe there's some tenderness, like mild, when you palpate along the muscles. So you kind of go back and you maybe order some tests, and one of those things you want to check is the urine, because he did note that he had some dark urine. So your nurse comes back and says, this patient can't, is not really able to urinate or give us a urine sample. Dr. Malhi, any thoughts about what you might say?
Yeah, a couple of things I would say is, first of all, if we're not able to get urine from an otherwise younger, healthy patient, I would worry about whether they're a little dehydrated. I'd see if we can encourage them to drink some fluids to get themselves to be able to go to the bathroom, or see if we can give them some IV fluids if they don't have any contraindications to receiving IV fluids, to encourage them to urinate on their own. But if we are not able to get urine, despite all of that, I may consider getting a bladder scan, or getting our nurse, or even going in myself and taking a look at the bladder with the ultrasound to see if there is urine there. Are we not getting urine because the patient isn't making urine? Or are we not getting urine because the patient, for some reason, isn't able to excrete the urine? And if there is urine in the bladder and there's something there that I'd like to be able to get a sample of, we can always ask our nursing colleagues to put in a Foley catheter to be able to help get the urine and be able to visually inspect the urine and then send the urine for further testing.
Excellent, excellent. So I like it how we kind of like to start with kind of the most minimally invasive intervention. So kind of, just giving some oral fluids, seeing if we can get the patient to drink, and kind of just exploring what's going on first, and then kind of escalating what you might do depending on that. So we end up having to put a Foley in this patient. And so advance the slide, please. And this is what we see. Dr. Salazar, how would you describe this finding?
Well, that's a urinary catheter bag. So that tells me that that's got to be urine in there. And that's got the classic Coca-Cola sign, which can only be associated with a handful of things. And that includes blood and other items. So yeah, the Coca-Cola sign right there for you.
Okay. So I want everybody to just think about what this could be. Maybe type it in your chat box, and let's advance the slide.
Let's go ahead and deploy the poll there. Rachel, let's see what you guys think that we're dealing with. So what is the cause of the findings in this urine bag, which we described as Coca-Cola urine? You may not have just one right answer, but what is the most likely? And as you're thinking about it, you're going to have to get really good at test taking, not just now, but in the future. And so remember, in medicine, it's rarely black and white. A great clinician loves and thrives in the gray area. And so there may be more than one right answer, but there's usually an even better answer. So let's take a look at see what you guys have. And Rachel, we can, and they're right there. Hey, not too bad, guys. Not too bad. A lot of blood, a little myoglobin in there, creatinine kinase, and urea nitrogen. So let's see what Dr. Hernandez wants to teach us.
Okay, let's advance the slide. So this is rhabdomyolysis. That's the diagnosis here. And so this is caused by any disease process that causes muscle cell death or lysis. So what's happening is the muscle cells are dying or coming close to dying, and they are like, they might break and kind of their contents will be released into the blood. So this can present with muscle pain, weakness, and dark urine. That's like the classic triad. It can be, and what some underlying things that can cause this, it can be associated with drug abuse, intense exercise, or even intense agitation. Medications can cause this, crush injuries, something that's actually physically crushing the muscles, seizures, or a prolonged downtime, meaning sometimes an elderly person may fall and be down for a while, and they can be kind of just lying on their muscle, and then that can cause this to happen as well. Patients may present with tachycardia, fever, muscle tenderness, but this is not 100%. So some tests you want to order. So one of the main things that you want to order is a creatine phosphokinase, also known as CPK. And really, if it's above 1,000, that's when you worry about this entity. But when it's about 5 times the upper limit of normal, that's when you're really worried about it causing complications such as renal injury. The urinalysis looks like that Coca-Cola tea colored, and it looks like blood, and you might think it's blood, but there's actually not blood in there's actually no RBCs, which are the red blood cells, but it's actually myoglobinuria. So it's a myoglobin that is being secreted and causing that discoloration. You also want to definitely check electrolytes when you're testing in this entity, because they can be very off, essentially because if your kidneys are being affected and not being able to purify the blood, then you will get elevations in your electrolytes. Advance the slide, please. So one of the treatments, so first of all, these patients can get very sick. So we in emergency medicine especially love our ABCs, which stands for checking the airway, the breathing, and circulation of a patient. You'd want to insert an IV and have them on the monitors. You want to get an EKG, and the mainstay of treatment for this entity is really early aggressive fluids. So you want to address the underlying cause. So if they're were found down, or if they are, in a traumatic or in a crush situation, you want to remove that. If they were taking a medication that was causing this, you want to cease them taking that medication. If they're having a seizure or if they're agitated, you may have to use medications to stop a seizure or to calm them down in order to kind of stop the ongoing muscle injury. Then we talked about the fluids, and then you want to correct any electrolyte abnormalities that come up. And some of them will be like in terms of potassium, phosphate, uric acid, and calcium. If this is severe, this can affect your kidneys and you can cause renal failure. And if you have renal failure, that also may lead to acidosis, arrhythmias, and shock. And so if someone actually has, for example, very, very high potassium in their blood, they can potentially go into an arrhythmia and die from this entity. So if it is severe, they may need to get emergent hemodialysis. So the disposition here is usually these patients get admitted if their creatinine is above that 1,000 mark. Sometimes the creatine, I misspoke. So if that creatine CPK level is above 1,000, if it's hanging around 1,000, I have had some patients where I will maybe give them some fluids and recheck it. And if they have no electrolyte abnormalities and I recheck it and that number is going down and their renal function looks normal, then we can potentially send those patients home. But anything above that that's persistent, then we would be wanting to admit them, monitor them, and continue to trend those levels.
Thank you, Dr. Hernandez. That was phenomenal. So how about we take some questions and answers. So let's start with some rapid fire ones. Danielle Armstrong very wisely said recent muscle injury. She had a concern for rhabdomyolysis due to kidney injury. Danielle, that was outstanding. Dr. Hernandez, a student wants to know what causes the lack of urination in this case. Are they dehydrated because the cell's lysis is occurring?
Yeah, so that's essentially, I mean, that's really kind of what it boils down to. Their cells, your cells are lysine. You're having all these extra byproducts in the bloodstream. Also, it tends to kind of be compounded by dehydration. And a lot of times, for example, this can happen in young patients that are exercising strenuously. So this has kind of been known as a CrossFit disease as well. So when you're intravascularly down, then, and you have all these extra byproducts, then your renal system is not able to filter as well, and so that kind of can cause all the buildup and cause these issues down the line.
Phenomenal, thank you. Dr. Malhi, we're gonna look at the earlier case. For the case about paronychia, Kira wants to know, I see the treatment can include an oral antibiotic. Are there any concerns over Staphylococcus aureus becoming antibiotic resistant?
Yeah, absolutely. So there are types of Staphylococcus aureus that are what we call methicillin resistant or MRSA infections that are already resistant to several of our first line antibiotic options. And so depending on the patient, depending on the clinical history, so potentially what kind of injury did the patient suffer, or what are their other social risk factors that could potentially cause them to be more concerning for a potential resistant type of Staphylococcus aureus, or even any other sort of resistant bacteria or bug, you want to take into account those things and potentially tailor your antibiotic treatment options. So while for a normal cellulitis or skin infection, you may want to consider kind of your entry-level antibiotic regimens, like things like cephalexin or other antibiotics. In situations concerning for MRSA or these resistant bugs, you may want to step up your antibiotic game to things like doxycycline, Bactrim, or even vancomycin or clindamycin that have more of a targeted approach to resistant bacteria.
Thank you so much. Gonna go back to Dr. Hernandez and 2 questions on herpes zoster. Number 1 is, how is herpes zoster transmitted? Well, let's change that to, can it be transmitted? And the second one is, can herpes zoster present without a rash? And if so, how would you diagnose it?
Yeah, so for the first question, in terms of transmission, can be transmitted through droplet and also through contact. So if somebody contacts the actual rash itself or the vesicles, then that can transmit it as well. A lot of times, if the lesions are crusted over, and so there's no kind of liquid or pustules there, and it's completely crusted over, it's definitely less infectious, and we usually advise them to keep something over the area. This becomes important because if someone has zoster or even chickenpox, let's say, then you do have to remind them or warn them that they shouldn't be around others that are immunocompromised or even pregnant, because they can spread the disease to them. And for example, if a pregnant woman can have a worse course with this than someone who is has a full immune system. The second question was, remind me the second question.
If can a patient present without a rash?
Right. Okay. So yes, 100%. The patient can present without a rash. Now, if it's after they've already they can have multiple outbreaks of this, throughout their life. So they may already know and come in and say, this is my zoster pain. If it's a chronic issue for them, they may know. If this is a first presentation, it can be very tricky. And as I said before, just using the example from our case in terms of a woman complaining of abdominal pain, there's so many things that could be dangerous or need surgery that we would have to consider in someone who is presenting with abdominal pain. However, so zoster would probably be the last thing on my list in terms of thinking about, well, I would have it on my differential, but it wouldn't be the first thing that I would diagnose without ruling out those those issues that may need surgery or acute intervention. So if they had zoster of their right lower quadrant and they're tender in their right lower quadrant, I may want to get a CAT scan to rule out appendicitis in that case. If it's a female, I might want to definitely check or get an ultrasound of their ovaries to make sure it's not an ovarian pathology before I conclude with this could be zoster. I think sometimes if it's in another area, maybe it would be a little bit easier to think about without having to go down the line of excluding something more serious, like if it is on an arm or an extremity and maybe if they are very hyper tender, like, if I just, they're very sensitive, I just lightly brush and they are having such intense pain. And also think about how it infects the nerves and along a dermatome, because the pain at least should be traveling along the dermatome as well. So those are just some clues. But again, this is a case where they could have been sent home when there was no rash, without a diagnosis, and then kind of bounce back when that rash comes up.
Very transmissible. Should be really careful in sending patients home who have very young children, infants, or the elderly. These infections can get them in trouble. Dr. Malhi, I'm gonna get back to you on this one. For rhabdomyolysis, how long should the aggressive fluids be? A few hours, a few days?
Yeah, so if we're keeping them in the hospital, then we have some markers that we can check. So repeating that creatine phosphokinase, the CPK, and watching it downtrend is one of the markers. If they have electrolyte abnormalities, seeing those get better, seeing their renal function improve. But for patients that potentially are doing okay and we're discharging home, and like Dr. Hernandez mentioned, if their labs are looking okay, one of the things I will let them know is lots and lots and lots of fluids at home, and do that until your urine has normalized to a normal color. So that can be an indicator for them in their home setting if they are otherwise, not in a hospital where we can check repeat labs.
And somebody asked, I'll take this one, what type of fluid would you want administered to avoid edema? I'm going to say lactated Ringer's is a very good physiologically friendly fluid that we can give patients. We're going to take a live call. I'll handle here the next one. I would like Cheyenne to have Maithili Diaz, Maithily, one of my IG buddies, ask a question. So Maithili,
let's see. I'm looking for the name right now. Could you spell it one more time?
Sure. Diaz is last name Diaz, first name Maithily, Maithily.
There we go. I see them. All right. They are unmuted.
Go ahead, Maithily. How are you?
Looks like they're still trying to connect here.
No problem.
Okay,
oh, there she is. How are you?
Good.
Thanks for being with us. You asked a really good question, so can you ask it for the rest of our friends? I'd be happy to field that for you.
Yes. So it was more so beforehand, but of course it applies to ER doctors. But how do you thread the line between becoming desensitized to giving the kinds of news of GBMs or possibly like in the ER of death and those kinds of notices, but also not becoming too invested in your patients?
When we were all training, this is not a skill that you learn. This is not a line that you learn to thread very carefully right off the bat, because you can swing wildly in both ways. I've learned the following: the older I get, the more I tend to swing toward being more human with patients. That it is okay to become emotional. It is okay to become a little bit invested. And I've not quite become desensitized like many people would expect me to be. So I would encourage the next generation of docs to really embrace humanism in folks. You're going to be tired, you're going to be exhausted some days, but at the end of the day, remember that the family members, for somebody who's going through a really tough time and a patient who's going through a really tough time, really rely on you, and the way that interaction goes may dictate the way that their care is going to go and their outlook on life. So it is perfectly okay to be human. You will have some moments where you can lose empathy and become desensitized, but the older you get, the more gray hair like me that you get, the more you're gonna go in that other direction. Thanks, Mike TV. Thank you for your question. Let's take another live one, and this one I'm gonna give to Dr. Hernandez. We got Mia Tamayo, Shayon, Tamayo, first name Mia.
Oh, I see them. Let me go ahead and unmute them. Unmute. All right, they're ready to go.
Hi, Mia.
I guess they're still connecting. Oh, there we go.
Hello, can you hear me?
Yeah, we can hear you. Hi, Mia.
Okay, so my question was regarding the patient and doctor when he was giving the diagnosis. I was wondering, how would you deal with the situation in terms of, say the patient came into the emergency room and you get the test results back and they have to go in for emergency surgery and you don't really have a lot of time for the patient to process the diagnosis or the information, nor get their family members there. How would you deal with that situation?
And especially, say, for example, I think part of your question was, what if they need to go to surgery right away? How do we deal with kind of not having enough time, Dr. Hernandez?
Well, I will say that most of the time you will have more time than you think, especially just because it takes sometimes a little time for preparations to happen, to kind of communicate to the surgeon that this is what's happening. You know, it depends on the situation, I would say, because if it's something that you have been seeing and working them up in the ER, and that then will have to be going to surgery when you get kind of your results back and you make that determination, usually we'll have a little bit of time because you still need to communicate that to the surgeon. You still need to, communicate with the OR so they get that ready. Where something like that may happen when maybe more in a trauma situation, if somebody has with like the surgeons are like right there and they're ready to whisk them away, and you have a really, really short amount of time to really get them the information. I mean, you know that, you are working within a healthcare team. So when you consider having to deliver that information, I would probably ask the patient if they want me to get anybody on the phone with them as we talk about it, just because that we are, kind of having a short and a brief time frame, and that they are very ill, and that we need to get them to their next level of care as quickly as possible. So maybe I would say, do you want me to just get someone on the phone? Do you want to call them? You want me to call them on your cell phone? Sometimes, that can help as well. They might have their communication device with them, and you have to just be very clear. You want to show empathy and be sensitive to the situation, but I would emphasize that is the most important time to actually communicate the truth to them. Like if they have something that's life threatening and they're having to go into surgery, they may not come out of surgery. So if they want to talk, and if they need to talk to a family member, if they are so inclined that they want to talk to a family member, I would encourage them to do so, because this is something that is very serious. And I would say that, time is short. I would definitely want to answer more questions. When the surgeons take over, they will be there to answer some questions also. And so I would encourage that. I did personally just, I had a patient who came to the ER and they had a headache, and it actually turned out to be a pretty severe brain bleed where we did need to intubate. So we needed to put a tube down to help them breathe. But I honestly, given the patient's whole picture and their comorbidities, I honestly was not sure that if they were intubated that they would ever be extubated, meaning that they would able to remove that patient from the tube. I really didn't feel confident that I could tell the patient or the family that this would be resolved. So I did say that this is, something that's very serious. Once the patient is intubated, I did not know whether they were going to be able to be extubated. So I did communicate that to the patient and the family. And, it offered them the opportunity to have a moment with their family member that they may or may not have had the opportunity to have later.
In some situations are so time sensitive that the following approach usually never fails for me. I know you're really scared right now. What you have is the following. In order for me to help you the most right now, we need to get you to surgery or to the catheterization lab. Everything is going to be okay. I promise. Just those few words, when you're really pressed, go a long way. I'm going to shoot this one toward Dr. Malhi. This is a really good question. What is the best way to inform patients, their power of attorneys, and family members on their choices when it comes to end-of-life care? Say that the patient's prognosis is not great, but the power of attorney still wants aggressive treatment. How do you balance informing them on their choices, but being firm on the reality of the situation? Thank you for that question.
I think Dr. Malhi just went to restart her computer.
Oh, no problem. No problem. Then I'll handle this one. That is an excellent question. Family members are very invested in. Oh, there you are, Jupin. I'll handle this one. Family members are really invested in their family members' care, especially if they have a power of attorney or other legal standing related to the patient's medical decision making. In that situation, I'm gonna give you the best piece of advice. I try to guide the conversation both to the family and to the patient according to not what the family wants, but what I think the patient themselves would want. And I urge the family to make decisions based on what the patient's decisions would have been, what they would have wanted. I know I, as a family member, what I would want. I never want to see my parents, my loved ones, have something bad happen to them. But I know that that is my opinion, and I'm not making decisions based on my family members' thoughts, their feelings, their values. So that's a tough conversation to have. Thank you for that question. We're gonna take a live question right here, and this one is gonna be Fadumo Bashir. B as in boy, A-S-H-I-R. First name Fadumo with an F.
All right, there we go. I see them and they are unmuted.
Hi, Fadumo. Whenever you're ready, go ahead and ask your question.
They're getting connected, it looks like.
All right.
There we go.
Hi.
Hi, Fadumo. How are you?
Good, how are you?
I'm good.
My question is, how do you deal with patients who are in denial when you share information? Because I know you build that trust and everything, but sometimes from what I've seen from shadowing, I see like patients don't take that medical advice and like form their own opinion, obviously, because they have the right to their own opinion. But I don't know, like if they don't take your advice, like what do you do in a situation that's serious?
Or comparatively, what if a patient just completely shuts down when you're trying to deliver news, or they don't want to talk anymore? Dr. Malhi, what would be some advice that you would have in that situation?
Yeah, so that's a great question. I mean, it can certainly be a little bit of a tricky situation, and you're right. You have to kind of tread the line between giving the patient the recommendations that you have, making sure they have all the information, but also, again, respecting their autonomy and respecting their decision-making capacity and their right to kind of guide their own care. So what I would do in that situation is first kind of empathize with the patient. Oftentimes I find myself saying things like, I can imagine that this is very overwhelming to hear, or I can imagine this is really not what you expected to hear, and there might be a lot you need to kind of process. So sometimes I'll just step away from the situation. I'll say, I'm gonna give you a few minutes to kind of think about what we talked about, reach out to friends or family if you'd like to process the conversation we've had, because I want you to be able to ask me questions that are important to you. And then I'll step out of the room, give them 10, 15 minutes, come back and readdress the situation and see if anything has changed, if they have questions that can maybe help them better understand or deal with the information they've been given. That doesn't always do the trick, of course. And at some point, if I'm feeling like the patient is not really understanding what I'm saying, again, like you kind of mentioned, I can't force my medical recommendations upon anyone. I make sure that I'm very clear and concise in the information that I'm giving. And if I'm discharging them from the emergency department with this kind of news news, I make sure that the paperwork they're receiving on discharge, again, reiterates the conversation that we had. We discussed the possibility of cancer. We discussed the probability that today's workup may indicate cancer, and you need to follow up with this physician. We've made these referrals, and give them an avenue to seek further care. Make sure just because they're in denial, you're not, saying, okay, well, there's nothing more we can do for you. Give them the options that you would give anyone else. Set them up with the right appointments. Give them the opportunity to continue to seek care for their issue at hand. And I think beyond that, there's, you kind of have to leave some of it up to the patient as well, but make sure that they know where they can go to seek further care, to ask further questions, and let them know that you're available for that.
Thank you for that. We're going to take two more questions. I'll answer the first one, and the last one is for Dr. Hernandez. This is a really good question. What do you do when you're delivering news on a pediatric patient? How does it differ when it is a child or a teenager? So my best piece of advice when it comes to that, you need some additional training and frequent exposure to pediatrics and their parents, because now you really have two sets of patients in there. One of the main skills that you have to employ is how to work closely with a childhood social worker that specializes in this type of care, who can facilitate the conversation and really bridge the gap between your medical part and the pediatrics patients' understanding of the situation. So I never do these alone. I always, thankfully, am blessed with child life specialists who can assist us with delivering bad news, and then I can speak to the parents in private if needed. And the last question is going to be for Dr. Hernandez. Dr. Hernandez, one of the questions about the paronychia was, can these infections become more severe and cause things like gangrene, necrotizing fasciitis, etc.?
So the answer is yes. That's kind of one of the complications. If the infection gets worse, there can be, depending on the organisms that are involved, it can develop into neck fash. It can develop gangrene. They can even get osteomyelitis would also be on the differential kind of when thinking about these paronychia. So the answer is yes.
Very cool. Well, ladies and gents, part of my commitment to you on our very first session was that our sessions would be an hour and a half. Everybody has studying to do and families, and I want to be really respectful. Part of being a really good clinician is to be punctual with your things, and that's my commitment to you. You guys have some phenomenal questions. I'm really proud of you. This will not be the last time that we do this. What I do need from you in exchange for spending a little bit of time with you today is to give us some feedback, and you can do it through Instagram if you'd like. But I really want to hear about what you guys thought. We're doing this for you. This is our evening, and we're doing it for you, and we want to put a good product forward. So I am so grateful tonight for Dr. Hernandez, Dr. Malhi. I want to thank our student managers. We're going to thank Gloria Ramirez, Jasmine Rodriguez, Rachel Nguyen, Reagan Rosenberger, Stephanie Zhang, and Cheyenne Rabanasa. Please give them a virtual applause, because they really deserve a lot of credit. So with that, guys, make me proud. Continue the hard work. You'll get there. You represent the next generation of clinicians, and we hope to see you soon. Have a great night.